So this is a female, 61 years female. You can see the sclera, yellowish sclera of this lady, and there is a bag in the lower part, uro bag filled with biliary bile system. So this is a intervention done for obstructive jaundice. So let me give the details of this patient. A patient had a dull aching right upper quadrant pain for since 1.5 months, and history of jaundice and itching since 1 month, history of high colored urine and pale stools since 1 month. On examination, the patient is conscious, oriented, hydrated, afebrile, and icterus was present. Per-abdominal examination revealed the abdomen was distended, irregular, hard, tender mass 5 cm below the right costal margin, and it was dull on percussion. Digital rectal examination showed pale stool, that means it has clay color stool, which is common in obstructive jaundice. OGD examination showed a normal study, and liver function test, you can see the liver function test. This is total bilirubin 22.2, this is the conjugated bilirubin 15, this is SGOT, this is SGPT, and you can see the alkaline phosphatase is raised 395, and the protein is, total protein is 5.3 and albumin is 2.5. So with this investigation, we went ahead doing an ultrasound of the abdomen, which revealed, you can see the liver enlarged, IHPR system is dilated, right system is dilated, left hepatic duct is dilated, and there was a mass lesion of size. You can see the 2.06 into 1.83 into 2.2 centimeter lesion in the neck of the gallbladder, and there is another hyperechoic lesion seen in the porta hepatis of size 1.39 into 4.12 centimeters. With this, we went ahead with the CT abdomen. This is the CT abdomen. This is an angio CT. This CT abdomen revealed that ill-defined, there was a mass here. You can see the heterogeneous mass lesion in the occupying the gallbladder in the porta hepatis, involving the right and the left hepatic duct. It is involving the cystic duct and the neck of the gallbladder. So there was a dilatation of IHBR, right hepatic duct, left hepatic duct. There was a distended gallbladder, and the liver is also enlarged, and the liver was also enlarged. And there were multiple nodes. You can see that periportal, peripancreatic, gastrohepatic, parahepatic, and precaval lymphadenopathy were there. And this could not conclude our whether there was an involvement of the vessel or metastatic history. So we went ahead with CT abdominal angiogram, which revealed that the lesion, this is CT angio, the lesion from the neck of the gallbladder was, you can see the hepatic artery, right hepatic artery was abutting and it was involved, and there is a heterogeneous enhancing lesion in both, there is heterogeneous enhancing lesion in both the lobes of the liver, which shows metastatic in angio CT. So since we are dealing with the obstructive jaundice advanced case with metastasis, so we went ahead with doing a left percutaneous transhepatic biliary drainage. So externally it was done, and then internalized into the duodenum. So intercostal route on the right side was chosen. So selective catheterization of intrahepatic biliary radicals in the left lobe done with SIBA needle 0.018 wire, and left duct was entered and upgraded to 6 French catheter, and then 8 French 45 centimeters. The length of the catheter is 45 centimeters, passed up to the duodenum. After 2 weeks of post left PTBD, LFT shows a dramatic decrease in the total bilirubin and marginal rise of your total protein and albumin. So you have to wait for 6 to 8 weeks for the synthetic function of your liver to increase after PTBD. So let me have an introduction to obstructive jaundice. Obstructive jaundice results from obstruction to the bile flow from the liver to the gallbladder and then to the small intestine. Let me give some description about the normal bilirubin, which is 0.3 to 1.2 milligram per deciliter. 1 milligram, the conversion for milligram to millimoles is 1 milligram is equal to 17 millimoles per liter. Bile flow is 600 ml per day, but the hepatocyte component will be 450, cholangiocytic component will be 150 ml. So, the normal pressure of the biliary secretory pressure will be 15 to 25 centimeters of water. At 35 centimeter of water, there will be suppression of bile flow. So, there won't be any bile flow when the pressure increases to 35 centimeters of water. Go into the clinical evaluation. How do you evaluate a obstructive jaundice? The history is very important and examination is also very important. Let us go to the history. What history you have to take? I will divide the history because so that you won't forget what to be asked in a obstructive jaundice. General history, family history, drug history, history of travel to abroad, past history of any surgery and alcohol history. Coming to the general history, you should ask jaundice. In pertaining to jaundice, if the patient is having a pale stool or clay color stool, any dark colored urine or yellowness of the eye. Pruritus should be asked. Any abdominal pain, which quadrant of the abdominal pain you should ask. Fever, is the fever is there or not. Loss of appetite, loss of weight. So, pertaining to the gastric stasis, which happens in a mass occluding the lumen of the GIT, you should ask for early satiety, vomiting, belching and ball rolling movements. So, pertaining to the UGI, I will divide the symptoms into UGI symptoms, lower GI symptoms, central abdominal symptoms, signs of liver failure, signs of pancreatic insufficiency and renal history and metastatic history. Coming to the upper GI symptoms, I would like to ask for dyspepsia, vomiting, retrosternal burning, nausea, regurgitation, hematemesis and melena. Pertaining to the lower GI, I will ask for altered bowel habits, any mucoid stools, any bleeding per rectum. Pertaining to central abdomen, we will ask for pain, visible peristalsis, the signs of liver failure, which I will give you, which is gynecomastia, glubbing, palmar erythema, spider nevi, koilonychia, flapping tremor, pallor, dehydration and caput medusae, that is veins radiating from the umbilicus.